Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. What I'm going to be sharing with you today is a special case for tip number 100. This is a case of Swyer syndrome with gonadoblastoma and dysgerminoma. So this is a case of a 10-year-old female patient who presented with bilateral ovarian masses from which a biopsy was taken. And this is the low power magnification of the biopsy with cells growing in sheets with a clear cytoplasm, pleomorphic nuclei, some inflammatory infiltrate, and the tumor cells were positive with SAL4 and PLAB1, but negative for other germ cell tumor markers. So the diagnosis of dysgerminoma was rendered, and the patient went on to receive 3 cycles of chemotherapy. Now, after she completed the chemotherapy, there was the plan to for the patient to undergo resection or oophorectomy on one side and cystectomy on the other side. And what was really under the microscope of the cystectomy specimen was nothing but completely necrotic tumor. This is one slide. This is the other slide showing some inflammatory cell infiltrate and fibrosis, but not much really in the way of the dysgerminoma cells that were present in the true cut diagnostic biopsy. What was really very interesting is that some of the sections contained what would be very similar to gonadoblastoma. So we have stromal cells surrounding lumina containing acidophilic secretion, but not much in the way we did not see any of the dysgerminoma cells within the formation. And my explanation for this was that because of the response for the chemotherapy in the dysgerminoma component of the tumor, the same cells disappeared from the gonadoblastoma component. This is another area showing exactly the same morphology with the stromal cells growing around lumina containing acidophilic secretions and even some calcifications and ossifications, but not much in the way of the dysgerminoma cells, which would be a component of gonadoblastoma. What was really interesting is that at one section to the very edge of the main oophorectomy specimen was this formation. To me was kind of in a way reminiscent of retitestis. But what was really very fascinating is that beside the fallopian tube, there was a structure running, and on sectioning, the structure was nothing but vas deferens. And this is on high power magnification where we have the lining epithelium, and then we have the concentric layering of the smooth muscle around the epithelium consistent with vas deferens. And that really supported, in a way, my theory that the other component that was present in the sections obtained from the tumor or from the mass was probably retitestis. On immunohistochemistry, alpha inhibin was positive in the gonadoblastoma component, as was SF1 faint staining, but PLAB1 and SAL4 were completely negative. And remember, the patient received chemotherapy on the assumption that the patient had dysgerminoma, for which the dysgerminoma component showed complete pathological response around those gonadoblastoma formation, as well as within the gonadoblastoma formation, leaving those stromal cells as evidence for the original diagnosis. This is androgen receptor, beautifully positive in the vas deferens component, as well as in what I interpreted as remnants of the retitestis. So the final diagnosis in this case came as probably suggestive of Swyer syndrome. At that stage, I contacted the pediatrician and the pediatric surgeon, and I've asked for karyotyping. 10 days later, the karyotyping results came back as 46XY, confirming that although phenotypically this is a female patient, however, by karyotyping, apparently this was a male patient. And if you look into the karyotyping male profile versus a phenotyping of female profile, there are 3 syndromes, 2 of which will have evidence of testicular differentiation, and 1 will show a streak-only formation without testicular formation from which tumors develop, as well as other Mullerian organs like our case exactly, and that would support the diagnosis of Swyer syndrome. And remember that these dysgenetic streaks or gonads are prone to develop tumors, in particular gonadoblastoma with or without dysgerminoma. I hope you find this tip useful in your daily practice. Thank you.